Salters earned her medical degree from the University of Colorado Health Science. She went on to complete a general surgery residency and fellowship in trauma, critical care, and ACS and cardiac surgery at Oregon Health and Science University. She further specialized in advanced robotic surgery through a fellowship at Baylor College of Medicine at the Michael E. DePakey Department of Surgery Division of General Thoracic Surgery in Houston, Texas. In addition, Dr. Salters holds a PhD from Colorado State University, and she's board certified in both general and thoracic surgery. In addition to her clinical expertise, she's committed to education and community service. She's made meaningful contribution to the field through publications, presentations, and active involvement in professional societies, including the American College of Surgeons, Society of Critical Care Medicine, Society of Thoracic Surgeon, and multiple state medical association. Her clinical interests are surgical conditions of mediastinum, lung, chest wall, diaphragm, esophagus, and thoracic outlet syndrome, which we'll hear about today. She's particularly passionate about minimally invasive procedure, robotic surgery, and critical care medicine. I'm really delighted and privileged to have you with us in the team. It's been a pleasure having you. I hear nothing but great accolade and positive reviews from our learners and from our nurses, and it's been a pleasure to have you aboard. Thanks for joining us today. Looking forward to your talk.
Yeah.
Do you want me to?
That means everybody got their paycheck that I sent if you say good things about it. Okay, I'm going to start off this talk by saying sometimes in life you don't want to do certain things, but sometimes you're given certain things and you need to learn how to do them, because honestly, our ultimate goal is to provide a service to patients. This syndrome fell in my lap during COVID pandemic. Who in this room knows what thoracic outlet syndrome is? Wait, who's heard about it? Okay, who thinks they really know what it is? None of the thoracic, Aaron Gillespie cannot raise their hand. Exactly. One person raised their hand. I was the same way. I was like, maybe saw one or two during my residencies. And it was like, no offense, cardiac guys, but when you're doing a mitral valve and they're like, oh, did you see what I did? You're like, yeah, I did. And then you're like, I saw nothing. It was the same thing with thoracic outlet syndrome. Okay. Get the business out of the way. I have no financial relationships to disclose. Thoracic outlet syndrome for this talk and in the literature are going to be known as TOS. Okay. A big special thank you to Brian Bird, even though he tortured me with this when I was at Baylor. Again, during the COVID pandemic, everything shut down. We pulled some research projects off the shelf and said, okay, what are we going to do? He really developed the robotic first rib resection in this country and has actually been a phenomenal mentor, especially when I started doing these procedures on collegiate athletes and professional athletes. Talk about being nervous and needed to change your scrubs a few times during the case. Those were the cases that really made me learn a lot about it. Okay. I am not an expert in TOS. I think that's very important. Again, this sort of fell in my lap. I've sort of developed a love for it. I've tried to develop a better program, mainly surgical, and mainly also to get awareness out there as to what TOS is. Dr. Thompson and Dr. Pearl are two prominent vascular surgeons in this country that do TOS on a regular basis. They do about 250 to 300 cases a year. In my best year, I've done 25 cases. So I am by no means an expert, please know that, but I'm passionate, okay? So these are your learning objectives today is to understand the anatomy. If you don't leave with anything else today, I want you to understand the anatomy of TOS, okay? Understand how the anatomic alterations create the pathophysiology associated with TOS, identify key symptoms of TOS, describe a generalized diagnostic workup, and then describe management and treatment options. Okay. All right. So this is a board question. This is what you're going to see. This may be all you learn in general surgery for thoracic outlet syndrome. If you miss this question on your boards, seriously think about another career option. Okay, this is a 27-year-old right-handed dominant Major League Baseball pitcher who develops acute onset of right upper extremity swelling, has reddish discoloration of the arm, the limb's heavy, he has pain and numbness and tingling in his arm and hand. These are your options. Again, I'm giving a talk on thoracic outlet syndrome. If you don't get it correct, then we need to talk afterwards. acute cellulitis, biceps tendon rupture, venous thoracic outlet syndrome, lymphoma, a very large hiatal hernia with mediastinal venous congestion. If anybody chooses this question afterwards, we really need to talk, okay? Of course, venous thoracic outlet syndrome. This is really what you're going to see mostly on your ABSCID and board questions. Favorite question. Don't miss it. Make me proud. All right. Problem number one with thoracic outlet syndrome is the definition. This is from the American Association of Thoracic Surgery, the Academy of Orthopedic Surgeons and Hand Surgery, and the Society of Vascular Surgeons. I'm not going to read these definitions because they tell you nothing. So the main three societies in this country can't even define what thoracic outlet syndrome is in the literature. This is a problem, okay? So today we're going to have a little bit better description. I'm not going to define it, but we're going to have a better description of it. I mentioned this a little bit early, okay? The key to treating or understanding thoracic outlet syndrome is to understand the anatomy, okay? All right, I break it down into three categories. There's the bony structures, the muscles, and the ligaments. This is an area that I knew, like, because of my cardiothoracic fellowship, that there's a sternum, but man, I never thought I would be so involved with the shoulder and the scapula. So I had to learn a lot from my orthopedic colleagues. All right, let's start with the bony structures. You have the clavicle here, first rib coming around. Okay, notice how it comes around here, and your coracoid process. So the coracoid process is part of your shoulder, okay? All right, let's break them down. The clavicle. It's a sigmoid shaped bone. This is very important that it's sigmoid shaped because that's what allows it to function. It pivots. When you move your shoulder inward, that pushes the sternoclavicular joint inward, okay? When you move your shoulders outward, it rotates. You can't move one without rotating the other. It's a strut and a fulcrum. Okay, fulcrum. The strut is that it resists longitudinal forces. That means if this is resisting longitudinal forces here, all the forces are here and all the forces are here. That's going to play a key role in thoracic outlet syndrome. Okay, it protects the underlying structures, which you can imagine by now is what's called the neurovascular bundle, which is your subclavian artery, subclavian vein, and your brachial plexus, which are all three involved in thoracic outlet syndrome. The fulcrum, as I already sort of mentioned, is it pivots. It pivots at two main points, sternoclavicular joint, acromioclavicular joint, okay? Those play a key role in thoracic outlet syndrome. All right, the best rib that's ever known in the body is the first rib. If you thought you wanted to be unique, you need to name your first child first rib because it is so unique and different than any other ribs, okay? Look at the difference. This is the second rib, which is actually an unusual rib in and of itself, but the first rib is so different, okay? It's short, it's thick, it's flat. I've seen nothing like this. If you haven't seen a first rib, go to pathology and ask them to look at a first rib and compare it between the other ribs. It really is a very unique rib. It contains no angle. That means this. This is the angle of the rib. This is what allows ribs to expand. As we breathe, that can expand. This doesn't expand. It is straight. There's no angle there, okay? It has these unique grooves. Middle scaling muscle, anterior scaling muscle. If you've ever read or heard about TOS, those two are involved in TOS, okay? It also has a groove, and you can't see this on here, where the brachial plexus, mainly the T1 nerve root, actually goes through that region, okay? So highly resistant to movement. So none of the forces, this is not going to allow forces to be displaced. It's going to keep the forces intact, and that's what's causing the problem in its relationship with the clavicle. Okay, the coracoid process. It's this cute little hook-shaped bony structure on the anterior portion of the scapula, okay? It acts as an anchor for the shoulder because it's an insertion site of the pectoralis minor muscle. Pectoralis minor muscle inserts on ribs 3, 4, and 5, okay? It's really important in our accessory breathing muscles. So it's kind of way away from this area that we first started talking about. But what you see, neurovascular bundle goes right underneath it, okay? It also is the lighthouse of the shoulder for the orthopedic surgeons, meaning when you get to that process, be cautious because right underneath that is your neurovascular bundle. All right. There is this, what's called a theoretical spatial relationship between the first rib and the clavicle. So the primary patients with TOS, the primary pathophysiology for TOS is actually going to be the clavicle and the first rib. The secondary process might be the pectoralis minor and the core cord process, okay? But what you're going to know and what you need to know is really the first rib and the clavicle, okay? The spatial relationship is thought to be about 1.2 centimeters distance between those two structures. Okay, that's not very much, especially when we get to later in the talk and you see all the critical things that go through that area. But this is the relationship that they're talking about from here to here. This is about 1.2 centimeters, okay? That decreases as we raise our arms up or as we abduct that, okay? So a common thing with people with TOS is they have this overuse syndrome. Swimmers, baseball throwers, softball catchers, librarians, poster workers, anybody that's doing that repetitive motion is changing this dynamics and this theoretical spatial relationship. It's reported in the literature that this spatial relationship can be as small as 2 millimeters in thoracic outlet syndrome, okay? So there's also a spatial relationship between the core cord process and the chest wall. This angle here needs to be at 90 degrees in order to allow things to move under it. What happens with TOS patients is they will eventually internally rotate their shoulder because they're trying desperately to kind of open up this structure. As they internally rotate, they will shorten their pectoralis minor muscles and make this tighter there. And so they decrease that spatial relationship. All right, let's move on to the muscles and ligaments. Everybody have a good grasp of the bony structures? What's the two most important bones? Yeah, first rib and clavicle. Good. Don't forget the core cord process though. All right, so the two main muscles that you're going to hear about in the literature for thoracic outlet syndrome. So if you have another board question, which I don't think that you will, or an abscite question, is going to be your anterior and your middle scalene muscles, okay? Those two muscles insert on the first rib, middle, anterior. Posterior scalene, don't miss this one, does not insert on the first rib, okay? It inserts on the second rib, does not play a role in TOS. That's a trick question sometimes for you guys, okay? But I honestly think, I'm not even a fan of the anterior middle scalenes. I just like to take them off the rib. This is my favorite muscle, the subclavius muscle. It's this tiny little muscle that actually bridges the clavicle to the first rib at the level of the sternoclavicular joint, okay? And so it plays, I think it plays a significant role in the pathophysiology of TOS. All right. Other ones are, we talked about a little bit, we talked about the pectoralis minor muscle, but there's also this ligament here. It's called the costoclavicular ligament. I would say 99% of the patients that I operate on, this ligament is calcified. This muscle is very foreshortened and sometimes calcified. What that means, there's no movement in that joint. So all it's doing is just sitting there pinching on the subclavian vein, artery, and nerve. It's losing its flexibility with how you can rotate your arm and your shoulder. All right, so we talked a little bit about what is the role of the anterior middle scalenes. They actually elevate the first rib in the breathing process. So remember, the rib doesn't really participate very much in your breathing, but it does get elevated because of the scalene muscles to kind of open up your thoracic cavity and everything. The subclavius muscle pulls down the clavicle and elevates the rib. So you can begin to see the theme here is they're working against each other. One's pulling up, one's pulling down. It's narrowing that space, okay? The costoclavicular ligament already sort of alluded to. It connects the first rib to the clavicle. It's supposed to limit excessive superior upward movement of the clavicle and anterior posterior movement of the clavicle. So one of the things that you should also be aware of, you might find this on trauma. Anybody that has suffered a trauma to their proximal part of their clavicle, If it's a posterior subluxation, it's an immediate operation because you're jeopardizing your neurovascular bundle. If it's anterior, you can usually clinically manage it. You might see that with your trauma questions and everything. So posterior, think pushing down, compromising those vessels and nerves. Anterior, okay, you can just medically manage it. Okay, we talked about the costoclavicular ligament. We talked about that, sorry. Pectoralis minor, it is an accessory muscle to breathing. It shortens the scalene and the subclavius muscle. So remember how we talked about if you shorten them, then you're narrowing that space. Depresses the clavicle against the first rib, which narrows what's called the costoclavicular passage and that angle. I don't know if you remember that angle that I told you about the core process. It needs to be at a 90-degree angle. It actually internally rotates it and makes it less than 90 degrees. All right, putting it all together. Okay, sorry, I know it's a lot of information. At the end of all this anatomy, there's three main things that I want you to know. This is the thing that you hear about all the time, the scalene triangle. People have a theory that the scalene muscles become hypertrophied. I have not seen that in the operating room. What I see is they're very foreshortened. So it makes them look like they're hypertrophied. But I've actually taken them out and taken them to pathology and said, hey, give me the muscle weight on this versus the muscle weight on, another patient. And they're no different. So they're not bigger. They're just shorter. Okay. The second one, so what's important about this scalene triangle, subclavian artery and brachial plexus go through that triangle. Okay. This is your costoclavicular space. What's important about this is your subclavian vein goes through that space. They all three traveled through the subcoracoid process. So 3 tunnels. The actual thoracic outlet, which is funny, has nothing to do with this. Your thoracic outlet is this huge hole. In the front is your sternum, and the back is your vertebral bodies, and then you have your ribs. So even the name is wrong and everything, but I'm not going to change that. This is my working hypothesis. Okay, so if you give me a project that I didn't necessarily want to do in the beginning, and you say you got to do it, then you have to start making hypotheses. I'm going to stand up here and I'm going to lecture you guys. You can believe me or not believe me, but you should be questioning what I'm telling you so that you yourself can generate what is the next hypothesis. That's how we make changes in medicine. What's that old saying? Only believe certain percentage of what you read or what you hear. Always be challenging the literature, always be challenging, because you're going to find things in the operating room that are going to be like, oh, wait a minute, that doesn't quite fit what they taught me and everything. And that's where you need to start generating your own hypothesis. My hypothesis, as I said, in the literature, they want to say that the scalene muscles are hypertrophy. My hypothesis is they get foreshortened. So if you shorten a muscle and don't allow it to keep expanding, it's going to just get sort of static. And then it becomes dysfunctional. And so then it loses the functionality of the upper extremity. Okay. I also think because of that, because when you rotate this clavicle inward, this gets foreshortened. Okay. And I already mentioned too that sometimes is very calcified, and the ligament is also calcified. All it's doing is turning this clavicle down and closing this space. So then you become symptomatic from TOS. Second one is because you're rotating the clavicle down, the scapula also internally rotates, which then foreshortens your pectoralis minor muscles, which causes this angle here to decrease. Okay, it's only a minor part of TOS. In a minute, I'll show you what I do to work these patients up. Some people actually just need the pectoralis minor muscle released and they're symptom free. Most people will need their first rib taken out. But it's important to know the difference because you don't want to take out one and it not help. So you need to determine. Okay. We'll talk about the clinical types, epidemiology, and the symptomatology of thoracic outlet syndrome. I hope by now you kind of figured out that there's 3 types. Okay. This is really important. And this is actually where I became passionate with TOS. 95% of the cases are neurogenic. Okay. The ones that we all see in residency and the ones that we all find exciting are the venous and the arterial, but they represent only 5% of the cases, okay? In a minute, I'll show you a slide. 95% of the operation is on the group that only has 5%. That's the problem, okay? So I sort of jumped ahead of myself, but here lies the second problem with TOS. And I already said, 95% of the cases are neurogenic. Yet 95% of the surgical cases are vascular. It's the neurogenic patients that come to me that are begging me for help and understanding. They want to know why this is happening. Okay. We all know what a dead leg looks like or an ischemic leg looks like. Same thing with arterial. They get these ischemic changes, their hands cold, they're changing color. This is a surgical emergency. This is why it's part of that 5% that's operated on, because they come in with an ischemic hand. They have to go immediately get a thrombectomy, and the first rib is normally taken out in the same hospital setting. Okay. All right, venous. We talked a little bit about this earlier when I started my talk. These people come in, their hands, their arms can be warm or they can be a little bit cool. It actually sort of waxes and wanes, sort of, I think, on the position that they have their arm. They will have color changes. More commonly, they will be this reddish color. You can see it's kind of venous congested. It's very heavy. They can't hang their arm down. They're actually needing, to support their arm. They may have numbness and tingling in their hand. I think some of that's from venous congestion, not so much from like neurogenic issues, but it's important to know too, they can have a combination of all three of these factors, okay? The other thing you'll notice is sometimes they'll develop collaterals on their chest wall, meaning that, they're trying to decompress that vein that's being crimped between the first rib and the clavicle. This is more of a surgical urgency. Most of these people will come and they'll get started on anticoagulation therapy, and then eventually will have their first rib taken out. Some will get a thrombectomy in the first rib in this first setting, but I would say 99% of them, at least what my experience is and my experience of working with the vascular surgeons, is they'll be treated with long-term anticoagulation and then maybe 3 months later get their first rib taken out. All right, this is how neurogenic presents to me, okay? They have shoulder pain. They've been worked up the wazoo, if that's a term, by orthopedic surgery. They come with jaw pain. They've seen neurology. They've seen ENT. They have trapezius muscle problems. They've seen PT or physical medicine and rehabilitation. They come in with this atypical chest pain. They have had the multi-million-dollar cardiac workup, and most of them are this age. So not likely to be coronary artery disease. They come in with neck pain. They've been seen by neurosurgery for cervical problems. Again, they're this age, they're most likely not going to have neurogenic problems. Or they'll have what's called this unique occipital headaches or occipital pain. And again, they've been seen by neurology and neurosurgery. So this is extreme. I don't see this very often. They can have muscle wasting on their hand, okay? They can have deformity on their hand, but I don't really see that very often. I have seen it. It's an extreme situation because it's been going on for several years and there's been no relief in symptoms. This is the problem. There is significant provider resistance to surgery with these patients. They're extremely high maintenance. I'll show you a slide in a minute. Every one of my first-time neurogenic patients will get a 90-minute clinic visit and everything. They're not unless they have these symptoms, go back to that slide. This is what they're coming to me. They're coming to a thoracic surgeon with these symptoms. And I'm like, what the heck? Where am I involved in this process and everything? Okay. So this is the general list of medical disciplines that these patients have seen before they're actually sent to thoracic surgery. And I swear, I think sometimes they're sent to thoracic surgery. I know the orthopedic guys in Atlanta used to play a game on me and everything. They're like, oh, I know this person. You're going to love her. We're going to send her to see you. And I'm like, yeah, you guys are doing this on purpose and everything. But they see neurosurgery, they see orthopedic surgery, hand surgery, neurology, psychiatry, rheumatology, PM&R, physical therapy, occupational therapy, pain management, vascular surgery, vascular surgeons. Are there any vascular surgeons in the audience? I don't want to step on toes. They don't have any interest in neurogenic TOS and everything. They like the ones that come in acutely and say, oh, we got to get this done. This is the one group of patients that I tell my clinic staff, number one, you cannot go to lunch if I have a TOS patient, and do not leave me alone at the end of the day, because they'll stay for hours if nobody text pages me out or knocks on the door. This is the two most common things that I see when I walk into a room. They're extremely angry or they're already crying. And so it's really hard to get them to be like, get themselves together and let's talk about, okay, what symptoms are you having? What's the workup that you've had? And then to try to understand what, how I think that I can help them. All right, diagnosis and treatment. I'll speed it up a little bit because I'm getting behind, sorry. Here lies the third problem with TOS. It is a diagnosis of exclusion, meaning everything else has to be ruled out before you can say, oh, this person has TOS. I don't even follow this anymore, but that's what's in the literature. This is from the Society of Vascular Surgeons. But remember, I said earlier, they don't want to operate on neurogenic. They want to operate on the arterial and the venous. So this is very broad description. Okay. Again, I started out following this and then I was just like really learned a lot from my patients. So I no longer sort of just say it's a diagnosis of exclusion. The controversies with TOS, which we sort of alluded to, is your extreme variability in diagnosis. Okay. The variability is a significant amount of variability in the sensitivity and the specificity of any of the diagnostic testing. So everybody wants to get an EMG analysis. It's only suggestive of TOS, like neurogenic TOS, in 1% of the population. Cervical ribs, they're congenital abnormalities. They're only present in about, at most, 10% of the people and everything. So not likely going to be that. There's a tremendous amount of lack of experience and a universal protocol for the scaling and pectoralis minor injections. And a little bit, I'll allude to why I do that and everything. There's a lack of physical therapists. I was in the city of Atlanta, which I think is the 7th largest city in this country, and I had one physical therapist to do TOS with me because all the other ones did not understand TOS. And I would tell my patients, if you go to the physical therapist, first thing I want you to ask them is, what do you understand about TOS? And I swear 95% of them called me back and said they knew nothing. So then I finally found one person that could work with me. There's a lack of experience in proper imaging for the workup. And then there's a tremendous amount of resistance from the healthcare system to actually treat these patients. There's a variability in management. What's the pre-op workup? What's the intraoperative surgical procedure? What do you do post-operatively? Because it's not just about taking out the first rib. There's a whole lot of work that has to be done after that first rib's taken out. There's a variability in surgical techniques. There's a lack of institutional support. I swear, at the last institution, I was a one-man show, and it was frustrating because you need other people to help you with this process. Lack of true outcomes reporting, biggest problem. And I think this is why majority of people, high litigation, mitigation risk. Some of these patients have been in an injury and they're looking to sue. Okay, so you're just in line for the next one. The true incidence of a brachial plexus injury at the time of the procedure is really unknown. It's reported to be less than 1% to 50%. That's a huge range and everything. So you enter this with caution. Okay, what I do and why I do it. Remember, I'm not an expert. This is just a protocol that I've built up over the last few years. 90-minute first visit, very labor intensive for me. They complete a bunch of forms. I do an extremely thorough clinical exam. Why do I do this? Number one is to make the patient just actually feel important. If they're having to fill out a bunch of paperwork, they're like, oh my God, this person knows what she's doing. I'm answering all these questions. She's hearing what I'm saying. If I'm touching the patient and I'm doing a bunch of like maneuvers, provocative maneuvers, they really think that I know what I'm talking about and that at the end that we're going to figure out what this is. But you'll see, and these are just some forms. I'm just going to go quickly through these slides. This is 1 form, 2 form, 3 form. Everybody fills it out, no matter what. They all fill it out because it just needs documentation is key. Documentation is key before you even think about taking them to the operating room. Okay. Now these are these slides. These are patients that had congenital injuries at the time that they were not congenital, but at the time that they were born. But this is what I see with my patients. Okay, my patients, and I'm going to probably put this down in a minute. They don't come in and they don't have good proper posture. In the beginning of TOS, they're doing this. They're opening their neck, they're shaking their arm, they're trying to move their arm. In the moderate to late stages, they're coming in like this. I can barely move their arm because they're doing whatever they can do to get rid of the pain. So this stage is bad because when I take out the first rib, that means this is already foreshortened. That means that trapezius is out of whack. It means the shoulder is out of whack. And here's another one. So this is kind of a late stage. Again, these are birth injuries, so not really true of TOS, but this is what I see. They'll internally rotate their arm and they'll keep it close to them. So I look at what's their emotional status. I already told you they're either angry or they're crying. I look at their general posture. I look at their level of fidgeting. This is the fidgeting that I'm talking about. I just had a TOS patient coming from Atlanta and a couple of weeks to get their first rebound. She was doing this the entire video. She's like, I just can't get relief. I just can't get relief. The level of their shoulder, they'll either hang it low or they'll bring it high. They'll rotate their scapula. In the beginning, they'll rotate it outwards to try to open this up. In the later stages, they'll rotate it in it. The position of their arm and hand. Most people won't let their arm hang down. They'll guard it close to them. The color of their arm and hand. Temperature of their arm and hand. The strength of their arm and hand. And is there any muscle wasting, not just in their hand, but also along their arm. All right, these are the provocative tests that I do with every patient. We're not going to go through this. I'm not going to explain it. The purpose of this is to show you what I do with these patients when I work them up for TOS. So quite a bit. The reason, again, why I do this, you can see when you add these together, the sensitivity and specificity is still not very good. So I do this to, one, make the patient understand that I'm engaging with them and that I'm interested and I want to hear what their complaints are. I've learned a lot from the patients. Actually, in this group of patients, I've probably learned the most in my career than I have any other groups of patients. All right, everybody gets an EMG study. Why? I said earlier, well, it's only diagnostic in 1%. It's for documentation. Because I can't tell you how many people will come in and they'll have lack of like their decrease in their nerve function will be at their elbow. And so when I take out the first rib, that's not going to make this better. Okay. So they may have to go see an orthopedic surgeon afterwards, or if they have carpal tunnel syndrome. So it's really for documentation. I get a 3D of their chest with reconstruction. What that means is the radiologist takes everything out but the bones. They leave me the scapula and then they'll subtract the scapula because I'm looking at what is that spatial relationship here and also what is the relationship of the scapula. They get a functional ultrasound, and duplex arterial ultrasound. Functional means, so if you go get a duplex ultrasound of your arm, they're going to have it in one position. I want the arm above them and I want them to remeasure it, okay? They get a functional MRI, same thing. They have to be raising their arm up to tell me, because everybody can sometimes open it up and not show that they have abnormalities. It's when you raise that arm up, it's when it shows differences. They get TOS, physical therapy. This is, everyone gets this again for documentation, but it's honestly not that helpful, but they do. They get staged injections of the scalene muscles. So the anterior middle scalene muscles will get injected with Botox, not at the same time as the pec, because I'm trying to figure out. And then the patients will come back and say, what did you get the most relief? So what it does is it paralyzes the muscle to give them a little bit of relief. It's not long acting. It may only last hours, but if they come in and say, oh yeah, I got my best symptom relief is when I got the scalene muscles injected. That means the first rib needs to come out. If they say, no, I actually got my best symptom relief from when the pec minor was injected, that means the pec minor needs to be released first and everything. All right, this is what y'all been waiting for. Surgical approaches. There is what's called a paraclavicular. So supraclavicular, infraclavicular. All right, this is sort of the, I want to say, old school way. I think some vascular surgeons may still, look, they're already cheering me on. I think some vascular surgeons may still use this, okay? There's paraspinal. Oh, God. This is because if you've left too much of the posterior aspect of the rib in there, they're going to get symptoms because it's still pushing on the neurovascular bundle. There's transaxillary up through the armpit, okay? And then there's transthoracic. Some people use video assisted. I do robotic assisted. All right, this is a schematic. So this is one of the paraclavicular approaches. So this is what it looks like in the book. Look how beautiful. You're like, oh my God, I can see everything. This is what it looks like in the OR. I'm like, I don't see crap in there. And we've all been there as a resident or a fellow. They're like, oh, you see this? And you're like, yeah, okay. Maybe transaxillary gets a little bit better. You're going through the armpit to get to the first rib. Again, oh, look, you can see all this beautiful anatomy. What the heck? You're going through the armpit. I don't see anything. Okay. So I chose the way that I do it because one, I'm old. My vision's going, it's probably less than it was a few years ago, but the way that what you can see. So I'm about to wow you with what you can see robotically. I also offer an open invitation to anyone that wants to come to an OR and watch a robotic first rib with me. You'll be amazed and you're going to change careers. All right. This is what we see in the operating room. Okay. First of all, look how beautiful this anatomy is. Okay. Everybody in the room can see it. Okay. Here's your first rib. These are your intercostal muscles. Here's your second rib. Most importantly is that you see the vital structures. Here's your subclavian vein. You got, so your T1 nerve root, that's high risk for injury with this procedure. Phrenic nerve, high risk for injury with this procedure, okay? So we're really looking at everything. Now, what's interesting, we're looking at it from below. Okay, so what's key is that this is actually the inferior part of your first rib, and this is the superior part. This is where all the business is. All right, so what we do first is I start out by taking down the inferior portion of the first rib. This is a safe zone. Nothing's there that you're really going to injure unless you go deep over the rib, then you'll hit your vessels and your nerves, okay? Then we start to work on the superior aspect of the rib. This is where all the important critical structures are. So we take all this down to expose the rib. And I apologize, I had a video, but my previous employer wouldn't let me use it. But that's okay. So then once the rib is stripped of the structures, I actually use a neurogenic. So see, look, I've already made colleagues with orthopedic surgery, with neurosurgery. I use this really long drill and I divide the posterior aspect right near the spine. I try to leave less than 2 centimeters, so right up against the spine. And then I divide the anterior. Now, theoretically, they say, oh, you can divide the anterior with a bovie cautery or some equivalent thing like that. I see that the majority of these first ribs in the anterior portion are heavily calcified. So I have to use the drill to drill it out. Okay. Once I've taken, so the rib is now reflected downward. We've separated it from the spine. We've separated it from the sternum and I've reflected it downward. And I'm coming across the top just to release the scalene muscles. Back here is your neurogenic, like your arterial and your subclavian vein and the brachial plexus back here. So I stay right on top of the rib just to like slowly take it off. After I've gotten the rib out, then I actually strip the inflammation that's around the subclavian artery, subclavian vein, and the brachial plexus. Okay. All right. At the end, we're the only group that can do this. At the end, we check the function of the diaphragm because remember the phrenic nerve travels on the anterior aspect of the anterior scalene muscle. So very important that we can document that diaphragm was working at the end of the procedure. All right, oh, these are my 3 boys. This is what I do and why I do it. Okay. So a word of advice for any of you who have children or have children that have gone to college. Do not tell them, go to college and have the best time of your life, because this is the one and only time that they will truly listen to you. I don't think I've had more boys, and yes, this is actually my biologic son. I don't think I've had more boys that have enjoyed college as much as these 3 boys did. But I'm happy to report they all 3 graduated in May. So that is over. But questions?
Thank you so much, Dr. Salter. It's an excellent round of questions.
I don't expect a lot of questions. Yeah.
So, thank you very much. I enjoyed your talk. What is your thought about, have you compared or have done anterior scalenectomies and anterior as well as a middle scalenectomy instead of doing first rib resection?
So I think the hesitation to that is because the phrenic nerve, it's running, right across that anterior scaling muscle. So I think, at least from a thoracic surgery standpoint, is we're hesitant, like we just want to release them. We don't want to take out the muscle.
So what if you isolate, so when I do it, I isolate the phrenic nerve. I do checkpoint stimulator before and afterwards. So I do check the
Yeah.
diaphragm. So the reason why is I've done them both. I've always found first rib resections rather morbid.
Yeah. So do you do them? You do the first sections? Which approach do you use? The supraclavicular, yeah. And do you take out the muscles? Yeah, and that's that's a topic of not controversy, but that's a topic of discussion, because as you know, sometimes the outcomes aren't quite what you want. I think the outcomes aren't as good as they should be because we wait so long to operate on neurogenic patients. We really should be operating on them sooner than later, because by the time we operate on them, they've got all this other dysfunction. But that is a discussion. We've talked about, do we take out the muscle? Yeah. Do you take, what do you do about your subclavius muscle?
Divide it and resect it. I don't take
Yeah.
anything out.
Take it out. Interesting. Where do you operate out?
Here.
Here? I'm going to come see you one day then, if you don't mind. I'll come. My apologies. Yeah. I'll come see one of your cases one day. I would love to.
I love to come see you.
Yeah. Absolutely. Yes. We need to be colleagues because, there's very few of us out there that are willing to take this on. Yeah. Good. Any other questions? Yes, Dr. Walters.
How would you manage if you were in the decubitus position doing the robotic procedure, if you got into the subclavian artery or subclavian vein?
So a couple of things. I have gotten into the mammary. Luckily, I haven't gotten into subclavian. I just clip that thing and tie it off, and they're not going to get a cabbage, especially if it's on the left side. Their mammary is not going to be used, but you got a right-sided mammary, so you can use that later. I've not gotten into the subclavian, but when I was training under Dr. Burt, we played these scenarios. What do we do? What do we do? And so there is some bulldogs that we have that we can actually, with a robotic instrument, you can get proximal and distal control of subclavian pretty quickly. And then I call vascular surgery in, to assist me. If it's a small one and I put proximal and distal control on the vessel, I'll actually just do a primary repair. Yeah. But if it's pretty much, because you can imagine when you're with the robot, any little bleeding, you're like, what is that? So then you have to kind of get yourself together and say, oh, it's okay. It's just a little bitty vessel and everything. But I always try to make sure vascular is on standby. Yeah. All right. Aaron.
There's a
Your own
really
partner
big,
cannot ask questions.
no, I'm not gonna ask you a question. There's just a really beautiful video online. Dr. Elliot Servais, who's a very busy TOS surgeon, posted actually about a recent subclavian vein injury that he had and his surgical management using the robot. To Dr. Salter's point, you can very easily get proximal and distal control and repair it primarily actually with the robot. It's a beautiful view. You have the view, you have the instruments in. The key thing is you've got your little cigars, put pressure. And the lovely thing is often, unfortunately, your rib is still in for better or for worse, right? So you have something rigid to kind of push against, which is really, really nice. So you can get great control. I actually take out muscle also because I think it makes a huge difference in the outcome. Dr. Servais and I both do for middle and anterior scalings. We're actually doing a little clinical trial to see if we can sort out the benefit of it.
I agree.
Other questions for Dr. Salter?
All right, remember for your abside exam, venous TOS, that's the answer. Posterior scaling does not attach to the first rep.